Hello, everyone. Good afternoon, good evening. My name is Dr. Sarah Ellis, and I am joined by my wonderful co host, Dr. Chill. How are you doing?
Doing great. How are you doing, Dr. Sarah?
Doing great, doing good. Happy Wednesday, everyone. Welcome to the Functional Solutions podcast brought to you by the American Academy of Functional Health. How's your week been, Dr. Chill?
It's been great and busy, so I guess that's great. And yourself?
Same, yes. Busy, end of school year, wrapping up all the things. But excited that summer is here.
Y-
Yay.
I always forget that it's end of school year. Living in San Diego, you sometimes forget what season it is because I don't think the
Yes.
seasons change here. So I was like,
Yeah,
oh, it's already June.
yeah, exactly. It probably feels like 75 there. Yeah.
Yes, it's
Yep.
a little rainy, and you're in South Carolina, correct?
Yep. Over here in the East Coast, it is also rainy. It's actually storming right now, but classic spring evening.
I guess we're still in the June gloom
Yep.
part of
Yep.
this
Exactly.
weather, so
Yeah.
hopefully it'll be a good summer.
I hope so too. Hopefully, they've been talking about like hurricanes and stuff this summer, but we won't worry about that too much today.
Right.
Uh,
Oh,
yeah,
no.
I know. I know. Thank you all for joining us. Let us know in the comments where you're joining from and how your week has been. As you all know, each week we join you all to explore practical and science based strategies to help advance the field of functional medicine. And our goal, as always, is to provide you with clinical strategies that you can take into the clinic tomorrow to help your patients. And so, this week, in today's episode, we are going to be exploring neuroinflammation. Now, neuroinflammation is an often unrecognized driver of cognitive decline. And so today we're going to talk about specifically neuroinflammation and its role in the development of cognitive decline. But neuroinflammation can also play a role in the development of neurodegenerative diseases and mood disorders. Now, conventional approaches tends to focus just on symptomatic management, but functional medicine gives us a framework to kind of help identify and address both the upstream triggers that fuel the inflammation in the brain, as well as the downstream sequelae that can develop due to those triggers. So, tonight we are going to walk through three primary root causes to neuroinflammation and cognitive decline that are unfortunately not talked about very often in conventional medicine. So, if you are working with patients that are struggling with brain fog, fatigue, memory issues, or more cognitive impairment and cognitive decline, tonight's class is perfect for you. We're going to be providing you with practical tools and deeper insight into how you can think functionally about inflammation and brain function. So, let's start off and kick everything off with an image from the CDC that highlights kind of why we chose this topic. And we chose this topic because this map shows us the percent of adults 65 and over who have subjectively reported cognitive decline. So this is they sent out a survey and people responded as to whether or not they perceive that they have cognitive decline or memory loss. Particularly memory loss that is happening or getting worse in the preceding 12 months. Now, this data was collected between 2016 and 2021. And as you can see, subjective cognitive decline is kind of widespread throughout the United States, but of course, unfortunately, tends to be clustered in the South region of the United States, which is a pattern that we've seen time and time again during our classes. But as always, I encourage you to take a look at your state and see where your state falls if you see similar patterns in your patient demographics. Now, it's important to note that over 6.7 million Americans 65 and older are currently living with Alzheimer's disease. And that makes about 1 in 10 people who are 65 and over have some form of dementia. Now, in adults over 85, that number actually jumps to 1 in 3. Now, Alzheimer's is the sixth leading cause of death in the United States. We're mentioning Alzheimer's as it's one of the more well-researched and common forms of dementia, but these statistics also reflect dementia as a whole. Now, when it comes to demographic prevalence, we see that Black and Hispanic Americans are 1.5 to 2 times more likely than white Americans to develop dementia. And in fact, women account for 2/3 of all Alzheimer's cases, partially due to longevity and hormonal influences on brain health. Now, that topic can be a topic of discussion for many hours, but when you think about your patient demographic, think about how many patients you see who are 65 and older, what your racial demographic is, and whether or not they are presenting with signs of cognitive decline, and of course, caring for the women in your practice as well. Now, cognitive decline is defined as a measurable decrease in cognitive function, particularly in areas involving memory, attention, language, executive function, and processing speed. Now, in clinical terms, we see it kind of broken down into three categories. Usually, we have the subjective cognitive decline, which we see in this map where participants are given a survey and they are reflecting their opinion about their memory and their cognitive function. Then we have mild cognitive impairment. That's where, as a clinician, you are measuring decline in one or more cognitive domains. Now, someone with mild cognitive impairment, they do have cognitive decline, but it is not severe enough to interfere with their daily activities. And then once we get into dementia, that's a more advanced stage where cognitive deficits affect daily functioning and independence. So let's jump into our first quiz of the night. All right. So, which of the following is not considered a common root cause of neuroinflammation and cognitive decline in a functional medicine framework? So, we haven't necessarily kind of covered some of these root causes, but I wanted to ask this question just to kind of get your juices flowing. And you guys tell us what you are thinking, and then we'll dive into those root causes later on tonight. Option A, chronic blood sugar dysregulation. And option B, intestinal permeability and gut dysbiosis. Option C, long term statin use. And option D, environmental toxin exposures, much like heavy metals and mold. Now, again, we're looking for which of the following is not considered a common root cause for neuroinflammation. Leave your options or your answers in the chat. If you don't see a chat option, select the button watch on YouTube and you'll be able to comment through the YouTube app. All right, the answer is C. Now, statins do have many side effects in some individuals. However, it has not been correlated with cognitive decline. And so long term statin use has not been implicated as a common root cause for neuroinflammation. However, chronic blood sugar dysregulation, intestinal permeability or leaky gut, and environmental toxin exposure have been implicated in the development of neuroinflammation. And we'll talk a little bit more about that tonight. So, Dr. Chill, as a clinician, how have you seen, or how many cases do you see with cognitive decline? I know for myself, uh, a good bit of my patient population are seniors, so it's definitely something we're working on.
And then also in the functional medicine space, brain fog is such a prevalent symptom, right?
Yes.
And then just outside of, obviously, we're talking about the progression of disease here, especially with Alzheimer's and dementia, but
Mhm.
also working in the functional space, we also work at optimizing health, right? Many of our practitioners look at maximizing health and optimal health for their patients as well. And what are those things? What does that look like, right? Increased focus, increased memory, increased brain function, increased energy. These are all parts of that neuroinflammatory picture. So
Yeah.
this has an impact not only in the disease progression, but also in optimizing health. So when you're looking at some of the root causes that we're going to be discussing about, right, you want to start to think about, okay, how does this look for each of my patients in where they're at in their health, right? And you might have patients that are trying to prevent their disease progression, and you might have patients who are trying to optimize their health. And all of these aspects, you can utilize an aspect of this in all of those different phases of their health.
So good. Yes, a reminder of focusing on prevention and not just management. So good.
Absolutely. And then
Thank
you asked about how often am I seeing it. It's funny. We were talking earlier about our week, right? So
Yeah.
this week I've been primarily focused with all the practitioners that I am overseeing with the academy. The number one thing that I'm seeing this week is brain fog
Mm.
and cognitive decline. And guess what the main issue is? It's actually environmental exposure to mold. So I have
Ooh.
run through so many mold and mycotoxin tests with practitioners and
Yeah.
gone through some of the things that we're going to be discussing today. So I'm really glad that we're diving into this.
Definitely. And man, I mean, post COVID, so many folks have been struggling with brain fog and memory issues. So it's definitely not a condition or challenge that's only for the elderly, for sure.
Absolutely. It's
Yeah.
for the majority of our population, really. And it's because we're inflammation investigators, right? So, and that is involved with neuroinflammation. So, let's talk a little bit about neuroinflammation here and some of the causes and how it causes neuronal damage and dysfunction, leading to some of the issues and the symptoms that Dr. Sarah was referring to. So, neuroinflammation, this is when inflammation occurs in your brain or your spinal cord. It's driven primarily by the activation of what's called microglia. This is the brain's resident immune cells. So what it looks like in a healthy brain is that these brain cells, right, these immune cells in the brain, the microglia, they are meant to help clear debris and protect the neurons. But when when they're chronically activated by systemic inflammation, toxins, infections, metabolic dysfunction, these cells are going to release pro-inflammatory cytokines. They're going to release oxidative stress. They're going to have excitatory neurotransmitters that can harm the neurons, right? And these can lead to some of the symptoms. So let's take a look at an image. This was done in 2015, and this was a study done in Nature Reviews of Neuroscience. This article is really highlighting the impact that neuroinflammation has on the development of Alzheimer's disease. So we see in this image here what a healthy brain looks like. You have communication between the microglia cells. You have the protection of the astrocytes. This is neuronal homeostasis. Within a disease state or progressing into a disease state, what we're seeing is that there's a proactive, pro-inflammatory phase that keeps occurring, that chronically, that leads to neuronal damage, and these can lead to the progression of disease factors, right? And it is this environmental environment or this inflammatory environment that can really disrupt that signaling between the neurons, and it can impair mitochondrial function. It could damage the blood-brain barrier. It can lead to neuronal dysfunction and ultimately cell death. So how this shows up in the clinic is going to be cognitive decline, such as memory loss, slower processing. This happens with many of our patients, right? Brain fog, we're seeing this often with our patients as well. Fatigue is another main symptom that we often see. Mood changes. How often are we dealing with patients who have anxiety or having depressive symptoms, right? And all of these can lead for an increased risk of neurodegenerative diseases. So, from a functional medicine perspective, neuroinflammation is often really a downstream effect of upstream imbalances. What we mean by that is if you address some of the upstream causes, such as gut health, the immune system, detox pathways, these can typically help with neuroinflammation as well. This is why it's really important to do a effective intake with your patients. Look at all of the different body systems that are connected with each other, and then figure out which is going to be the primary upstream system that you want to work with that is going to help all of the other downstream effects, right? Like I was saying, a lot of times it's your gut. That's why we hone in on the gut so often within the podcast and also within the program itself, because often if you address the gut imbalances, it's going to help with all of the downstream effects, including neuroinflammation. And this is going to go right into our quiz 2. So let's pop up that question here. Now that you kind of understand what neuroinflammation is, which of the following best describes neuroinflammation and then its impact on cognitive function? Is it A, neuroinflammation is a normal part of aging that does not affect cognition? Is it B, neuroinflammation involves chronic activation of the microglia? This leads to neuronal damage and cognitive impairment. Or is it C, neuroinflammation is caused solely by head trauma and does not relate to systemic health? Or is it D, neuroinflammation only affects motor function, not memory or attention? We'll give you a few moments here. Feel free to post your answers into the chat. And you can post them by clicking on the YouTube button and posting it into the chat within YouTube. All right. So if you picked answer B, you would be correct. We talked about neuroinflammation involving the microglia, right? Those are the immune cells within the brain. And when there is chronic inflammation that's occurring, it can lead to an impairment of signaling. This can lead to neuronal damage and cognitive impairment. You're going to have all of those pro-inflammatory cytokines, the oxidative stress. This is going to lead to symptoms such as brain fog, memory loss, and even an increased risk of dementia. So now, instead of just trying to manage the patient's symptoms, the most challenging part and the most rewarding part of patient care is to find what is causing or contributing to neuroinflammation. Again, we are those inflammation investigators. And this is what exactly these are all the things that we exactly teach in the Advanced in Clinical Functional Medicine program. Today we're going to talk about 3 of the root causes and contributing factors to neuroinflammation. So pay attention to these, because this is what you're going to look for within your patients who are presenting with brain fog, memory loss, focus issues, anxiety, depression, fatigue, all of those things that are main symptoms that we are often seeing with our patients.
Very good. Very good. Thank you for really laying such a solid foundation for us to understand exactly how neuroinflammation impacts um, our function, our mental health. I think, tonight we're focusing on cognitive decline, but as you mentioned, those who have anxiety and depression,
Mhm.
those are conditions that are driven also by neuroinflammation.
It's a major part of it.
Yeah, yeah, for sure. Okay, so now that we have our foundation laid, let's talk about those root causes. So, the first of the 3 that we're going to talk about tonight is heavy metal exposure and its connection to neurological damage. Now, one of the key root causes of neuroinflammation from a functional medicine perspective is toxicant exposure. So, especially heavy metals. Now, during our training in our functional and nutritional advanced clinical training, we are going to walk you through a lot of those functional tests, especially a heavy metals test. And so that's because we know that chronic exposure to neurotoxic metals like mercury, lead, and aluminum have been linked to cognitive decline, neurodegenerative diseases as well, and behavioral changes. I actually, as I'm kind of talking through this, I'm recalling a documentary that I watched on Netflix, Dr. Chill. I don't know if you've ever seen it, and I can't recall the title, but it talked about it was an orthopedic surgeon who saw that when he would do joint replacements, hips and knees, he would see patients begin to present as if they had Alzheimer's and Parkinson's and cognitive decline because of the heavy metal exposure from the joint. And when he switched the joint to a non-metal form or element or whatever material, they actually reversed and their symptoms began to dissipate. So I'll do my best to find the title of that documentary on Netflix, but it was really interesting. And, this next image that we'll talk about, hopefully that will kind of explain a little bit of what that orthopedic surgeon had noticed. So if we look at this image from 2022, it's a study in the journal Antioxidants. This shows the ways in which heavy metals such as lead, mercury, arsenic, aluminum, and cadmium can induce oxidative stress in the central nervous system and the ways in which they contribute to neurodegeneration. So at the top, we see these five heavy metals, and they're causing quite a bit of inflammation to the brain. Now, these are some metals that, of course, are in our food sources, but they can be in our water, particularly if we're not drinking filtered water, as well as if you are a smoker, and of course, living in a rural area or near a golf course, along with occupational exposures as well. And what we'll see is that the exposure of these heavy metals in the brain causes changes in the neuron. And what we see is development of oxidative stress. We begin to see mitochondrial dysfunctions. The neuronal cells don't begin to function as they normally will. We also begin to see an aggregation of alpha syn proteins. These are the same proteins involved in the development of Parkinson's. And so we begin to see an increase in Lewy bodies, which also is presented in Lewy body dementia. With mitochondrial dysfunction, we're going to see an increase in those reactive oxygen species, an increase in superoxide dismutase enzyme activity. We're going to see a decrease in that. So we're going to see an increase in oxidative stress and a reduction in our body's natural ability to reduce the inflammation through enzymatic activity. And what we're going to see is neuronal death, particularly around those dopaminergic neurons. Then we're going to start to see changes in motor function and sensory impairment. And then generally, we begin to see the development of dementia as well as neurodegenerative conditions like Parkinson's. So let's talk about some of the ways in which heavy metals can lead to neurological damage. So heavy metals disrupt brain health by, of course, as we mentioned, leading to oxidative stress. Particularly mercury and lead are known to generate quite a bit of reactive oxygen species, and that can overwhelm the brain's antioxidant defenses. Also, excitotoxicity. Some metals can actually alter glutamate signaling and could make our neurotransmitters a bit more excitatory, and that can lead to neuronal injury as well. And then also, heavy metal exposure can disrupt the blood brain barrier. And so they can impact and degrade the integrity of the blood brain barrier, allowing more toxins and inflammatory mediators to enter and inflame the central nervous system. Now, the top three neurotoxic metals you should keep your eye out for are mercury. Now, of course, we know the more common sources of mercury are large fish and dental amalgams. They have mercury has been associated with memory loss, mood changes, and neurodevelopmental issues. The second is lead. This is a well known neurotoxin. Hopefully, we've been able to kind of clear out all of the old paint and pipes that may contain lead, but it's definitely something and definitely worth inquiring about on your intake paperwork with your patients. And then the third is aluminum, found in some acids, food packaging, personal care products, and it's been implicated in mitochondrial dysfunction as well. Now, the challenge is heavy metals are not easily removed from the body. And so, for example, lead is known to accumulate in our bones, and it has a half life of 25 to 30 years. And so, this is why it's so important to learn the proper evidence based protocols to help your patients. And you can find all of those protocols in your dashboard once you log in and get reacquainted with those modules. All right, let's get ready for quiz number 3. All right, which of the following is a primary mechanism by which heavy metals contribute to neuroinflammation? A, suppression of synaptic signaling through increased serotonin. B, promotion of neurogenesis and enhanced blood-brain barrier permeability. C, generation of reactive oxygen species and microglial activation. Or D, enhancement of glutathione production and reduced excitotoxicity. So, which of the following is a primary mechanism by which heavy metals contribute to neuroinflammation? Put your answers down in the chat. We'll give you a few more seconds. And if you put C as your answer, that is correct. Heavy metals cause neuroinflammation because of their ability to generate reactive oxygen species, leading to oxidative stress and activating our neuronal immune cells, the microglial cells. All right, so Dr. Chill, um, I do tend to run heavy metal testing on a few patients, and I've been it's been really fascinating to see the connection between environmental exposures, occupational exposures, and things that pop up on that test.
Absolutely, and I'm glad you brought up the heavy metals documentary. I now I need to kind of go watch that because it seems super interesting. But it's a main component in functional medicine is looking at environmental exposure, not only heavy metals, but things like mold toxicity or mycotoxins, which we dive into in our environmental portion within the program. But those are all things that are going to affect the brain function, right? And so it's really important to run those tests and figure out exactly what is going on, what the imbalances are, what we're being exposed to, what we're being overexposed to, and how to kind of mitigate all of that exposure for our patients to decrease their neuroinflammation and other inflammatory processes.
Exactly. Yeah. I looked it up and it's called The Bleeding Edge.
The
And
bleeding edge. Okay.
yes,
Well,
it
now
talked
I'm going to watch that.
about, yeah, it talked about a couple of things. So it talked about birth control, the vaginal mesh procedures, and then the metal hip and knee implants.
It's super interesting because these are all things that our bodies can't process, right? And can't eliminate properly. And so they just accumulate and bioaccumulate in our system, wreaking havoc everywhere.
Yeah, yeah, exactly, exactly. And I think that by building up their antioxidant stores Yes, thank you for sharing. Yep, the bleeding edge. Definitely enjoy that. It's a really interesting documentary. Um, but yeah, being able to kind of give your patients a bit of an anti-inflammatory toolbox,
Mhm.
or pack in some antioxidant activity, is definitely going to be super important.
Absolutely.
Um,
And that leads right into our next root cause for neuroinflammation, which is, if you have been in the program, you understand how important omega 3s are. And we discuss it often. But what most I guess most of our patients might not understand is the difference between omega 3s and omega 6s. So it's an opportunity for us as practitioners to really educate them on this. And many of your patients will not understand this. So what's occurring is that in our westernized diet, right, there's more omega 6s than omega 3s, and omega 3 to omega 6 or omega 6 to omega 3 ratios is really important because this is also a root cause to neuroinflammation. From a functional medicine perspective, it is this ratio that, if it's skewed, and most of our Western diet is skewing it because we are heavily towards omega 6 rich foods from industrial seed oils such as canola and corn oil. This is where most of the restaurants, most of the processed snacks, you'll often see it being cooked with canola oil or corn oil or being included within those snacks. And this can create a deficiency of omega 3s. And it's this imbalance that can promote a pro inflammatory environment, including in the brain. Omega 6s can be essential in the right ratio. But again, what I'm stating here is that we have the ratio at it's really imbalanced for our patients currently. Right now, it's from some of the studies and the research that's out there, the omega 6 to omega 3 ratio is anywhere at a 20-1 or higher ratio, when it should be at a 4-1 or even a 2-1 to cause an anti-inflammatory environment. So let's take a look at the difference between the omega 3s and omega 6s and what occurs if you have this imbalance of the ratios, right? So omega 6s, this is coming from your wild caught salmon, your trout, your fatty fishes, flax seeds, chia seeds. Omega 6s, these are going to be coming from industrialized nuts and seeds and grains and vegetable oils. So omega 3s is going to have your DHA, your EPA. These are all really beneficial for the brain, versus the omega 6s is going to have arachidonic acid and DPA. In small amounts or in the correct amounts, these are beneficial for our health, but we are having an overconsumption of omega 6s. And what is occurring is now many of our patients are going down the pro inflammatory phase or mechanisms down on that right hand side there, right? Because it's all of those omega 6s that are occurring. And when that is elevated, this is going to cause a chronic inflammatory state in our patients. This is going to activate that microglia that I was speaking about earlier. This is going to increase oxidative stress, and it's going to contribute to neuronal dysfunction. And this is going to manifest as brain fog, cognitive decline, mood instability, and increased risk of neurodegenerative conditions. So let's take a look at this even further and look at how polyunsaturated fatty acids or omega 3s can be a part of the mood disorders, right? So we're seeing here omega 3s, and on the outside, we're seeing the oxidative stress, the neuroinflammation, the neurodegeneration, the plasticity, the neurotransmitter systems, the imbalances of the HPA axis. What omega 3s can do is it can improve total antioxidant capacity. It can help with lipid profile. It's going to help with brain signaling and neuronal signaling. It's going to be an anti-inflammatory mediator, and it's going to help with membrane fluidity. And this can cause neuroplasticity and increase the neuroplasticity for us, decreasing the neural inflammation as well. This is why it's really important to look at your patient's omegas. A lot of times, your patients will tell you they're taking omegas, but when you take a look at the bottle, it's omega 6s, omega 9s, and there's a little amount of omega 3s. And guess what's happening? It's causing a pro inflammatory state for them. So we want to take a look at all of their supplements, including their omegas. They may be thinking they're taking a healthy omega 3, but it's our job to take a look at it, investigate it, and then adjust it for them. And what I typically recommend with omegas is that they're only taking omega 3s. And when you look at the bottle for them, it's only having the EPA and the DHA in it. And this is going to help with that ratio that I was talking about. So it's going to decrease that ratio more from like a 20-to-1 to a 4-to-1 is what we're going for, to have that healthy balance for your patients, leading to that anti-inflammatory cascade that we were mentioning. And so let's go into a quiz 4 that's going to talk about the imbalances of omega 6s now that you understand it more in depth. So this quiz question is asking, an imbalance in omega 6 to omega 3 fatty acid intake is going to contribute to neuroinflammation primarily through A, decreasing inflammatory cytokine production, B, promoting anti-inflammatory eicosanoids, C, enhancing the production of pro-inflammatory mediators from arachidonic acid, or is it D, increasing DHA availability in neuronal membranes? I'll give you a couple of moments here. Now that you understand it, you should be choosing C, enhancing the production of pro-inflammatory mediators from arachidonic acid. And from that picture that I showed you earlier, right? That omega 6, the intake of those industrialized seed oils, the canola oils, the corn oils, this is going to lead to that increased risk of arachidonic acid metabolism. And it's fueling that production of pro-inflammatory prostaglandins and leukotrienes. And it's going to cause that pro-inflammatory cascade. It's going to create that vicious cycle. And what can you do? You can increase omega 3s for your patients and decrease their omega 6s, leading to a better ratio for your patients.
I have a question for you. How do you assess a patient's omega-3 status? Are you doing like a nutritional review or do you do a functional test?
Yeah, there is a test that does an omega profile. And if you go to either Avexia or Rupa Health, you could even look up omega profile, and they'll often look up their omega 3s, their omega 6s, and their ratios. I think 9 out of 10 times that I've run it, the majority of those patients have been high on omega 6s.
Wow.
And it's causing that pro-inflammatory cascade. But what's interesting is oftentimes I'll run like a CRP with it, and their
Mm,
CRP can be normal, right? Within the normal range, or it's reaching to those higher levels, but it's really that omega that's a deeper look into their
yeah.
inflammatory. And we have to understand there's multiple inflammatory markers that are out there. So for us, we want to look at other markers as well. Is there something that you look at for your omegas with your patients?
Yeah, I do, I think it's called Omega Quant.
Okay.
That's the name of the test to measure that. And then, of course, when I do a nutrition assessment, I am kind of looking at, are they eating any sources of omega
Absolutely.
3s versus the omega 6s? Even folks who are like vegan and vegetarian, if they're eating a lot of seeds and maybe not investing in like high quality seeds,
Hmm.
definitely want to be mindful of their omega 6 levels. Yeah.
It's an important test from a functional medicine perspective, right? Because we're chasing inflammation, we're investigating
Yes.
inflammation in all areas. So really looking at all of those different inflammatory markers is important in helping
Yeah.
our patients investigate that.
Exactly. And then another lab test that we can use to address the root cause of neuroinflammation and cognitive decline is homocysteine. So, homocysteine is a sulfur containing amino acid. And when not properly metabolized, it can actually become neurotoxic and contribute to many issues, including vascular and neurodegenerative processes in the brain. So let's take a look at an image from a 2022 review article in the journal Biomedicines. Now, this is probably a bit of a tiny picture, but I love this image because it does a really good job of how having excess amounts of homocysteine can contribute to a variety of different pathways that ultimately lead to cognitive impairment. So let's start at the top. On the left, top left, we have physiology. So, unmodifiable factors, your patient's age and their sex. Modifiable factors, so their diet, their lifestyle, sleep, exercise. And then looking at their diet, is their diet rich in B vitamins? Is it low in methionine? And then, of course, you have to take into consideration their substance misuse, whether they are abusing alcohol or if they smoke cigarettes. From a physiological standpoint, those are some of the things that could lead to homocystinemia. Now, from a pathological standpoint, from the top right corner, there are a few things that could cause excess amounts of homocysteine in the body. There are a couple of diseases, so chronic kidney disease, type 2 diabetes, and heart failure. These conditions can lead to excess homocysteine. The use of certain drugs. So if you have a Parkinson's patient that's on levodopa, on any anticonvulsants, or even methotrexate, that can increase homocysteine in the blood. And then, of course, if you have a patient with a genetic mutation, particularly if they have an MTHFR mutation, that could lead to excess homocysteine in the blood. So, what happens when you have a patient that has quite a bit of homocysteine present in circulation? On the left side, that yellow path, we're going to see what happens from a vascular standpoint. So, excess homocysteine from a vascular standpoint, you're going to see a bit more cell proliferation. Patients may tend to develop fibrosis of the vascular smooth muscle cells. And then also, at the same time, it could cause inhibition of cell proliferation, particularly an inhibition of the cells that produce nitric oxide synthase. Now, remember, nitric oxide helps relax our vasculature, which is so great for our blood pressure. Now, this can ultimately lead to cerebral small vessel disease. So it's going to be even harder for our oxygen-rich blood to reach those smaller vessels in the brain. That in and of itself can lead to cognitive impairment. Now, excess homocysteine in the vasculature can lead to increased oxidation. That's going to increase their oxidized LDL cholesterol levels, sets the stage for platelet aggregation, and so many more issues that can ultimately lead to cerebral large vessel atherosclerosis. Now, if we look at the effect of homocysteine on a degenerative pathway, we can see here that on one end, it can impact our methylation. So, this is where that MTHFR mutation plays a role, particularly if they're not taking methylated B vitamins. You're going to see them have, from a neurological standpoint, an increase in beta amyloid plaque formation. Decreased methylation can also lead to neurofibrillary tangle development and tau fibrils, which are seen in patients with Alzheimer's disease. And then, of course, having excess homocysteine, if we look in that middle section, it could lead to changes to different receptors for neurotransmitters in our brain, particularly as it pertains to GABA. And it also can increase reactive oxygen species formation in the brain, which turns on the inflammatory cascade and just further leads to more inflammation and cognitive impairment. So, what does this mean for you as a provider? If you have a patient that's presenting into your practice with brain fog, memory loss, cognitive impairment, it is very important to consider running a homocysteine blood test on them, serum test on them, to see if that is exacerbating their symptoms or potentially a root cause for their symptoms. Now, what they found is that, of course, we know that elevated levels of homocysteine is neurotoxic. It is an independent and modifiable risk factor for dementia. Homocysteine has been found to contribute to brain atrophy, oxidative stress, excitotoxicity, and vascular damage in the brain, all of which are implicated in cognitive impairment. And then researchers also found that people with high homocysteine have up to a twofold increase of developing dementia. And elevated levels of homocysteine are associated with an increased risk in developing dementia and Alzheimer's disease, vascular inflammation and damage to the blood brain barrier, as well as oxidative stress and excitotoxicity, which does contribute to neuronal injury. So, from a functional medicine perspective, elevated homocysteine often points to methylation dysfunction. So, you want to take a look at the source of their B vitamins, as well as making sure or having the option to dive deeper into genomic pathways in our advanced program in our modules. So, Dr. Chill, when we talk about homocysteine
Mhm.
and particularly its impact on cognitive health, I'm so glad that we brought this up because everyone talks about MTHFR mutations and their impact in health. And this is a great example of how having a MTHFR mutation can actually set your patient up for a difficult time with inflammation, particularly as it involves the brain.
Absolutely. And this is why functional medicine practitioners often, when they are recommending AB12, a folate, they're recommending the activated form, the methylated form, right?
Yeah.
For this, it's because of the possibility of the MTHFR mutation for our patients, leading to this inflammation.
Exactly, exactly. Um, and so it's so important when you all are investigating your patient's supplements and, kind of especially when they're coming in with a big old bag full of 20 different supplements, you want to make sure that it's in the most bioavailable form for them
Mhm.
and considering those genomic testing to make sure that their liver and their kidney and everything can metabolize those products as best as possible.
Yeah, I mean, two things that you could do right now for your patients is looking at their omegas, right? Making
Yes.
sure they're just omega 3s, looking at their vitamins and ensuring that they're in the activated form, the methylated form. If
Yeah.
they're not, make some minor adjustments. And just those minor adjustments can go a long way for your patients.
Yeah. And I don't even for a lot of my patients, I just give them methylated bees just to start with.
Hmm.
I know that some folks, it doesn't necessarily matter if you give them methylated bees and they don't have an MTHFR mutation.
Right.
But sometimes just to be on the safe side,
Absolutely.
methylated bees. Yeah, exactly.
It's an automatic vitamin source that I go to is the methylated B
Yes,
vitamins and folate, right?
exactly, exactly. Another supplement that we wanted to talk about tonight is glutathione. So now that we've talked to you about the foundations of neuroinflammation and cognitive decline. We've talked about those 3 functional root causes: heavy metal exposure. The second one was omega-3s versus omega-6s. And then we just got done chatting about homocysteine. So what do? Once you've kind of figured out what those root causes are for that patient, what's the next step? And when thinking about what product that usually is probably on all of our lists, is definitely glutathione. Now, glutathione is our master detoxifier, our master antioxidant. And when our goal is to increase our supplement or our glutathione levels, we tend to often reach for N-acetylcysteine. And I'm sorry if you hear my dog barking in the background. Dr. Chill, would you mind taking over this segment for 2 seconds? Okay. Hopefully, you all can.
Yeah, I could definitely take this over segment. Take over this segment really quickly. So let's talk about the body's master detoxifier. And this is what we call the master antioxidant. This can be really, really beneficial for inflammation in general. And it's also really beneficial for helping our body detoxify. And this acts mostly on the neuronal damage, and then it's also going to be helpful with depletion. Many of our patients that have some sort of neuronal damage will have some sort of depletion in their oxidative capacity, right? We talked about it with the heavy metals and environmental exposures, the omega-6s and omega-3s, and then even within the homocysteine levels. What does that lead to? This leads to oxidative stress. And one of the major supplements that you can do to address even all 3 of these is glutathione, because it's going to help with reducing neuroinflammation. It's going to be protecting the neurons, the oxidative and the mitochondrial damage. Is going to help with the detoxification with environmental toxins like heavy metals, even mycotoxins and mold exposure. And it's going to support cognitive performance and memory. This is a major one if you are working in optimal health and you are working on improving focus, cognitive performance, and memory with your patients. You want to look at something like a glutathione. And this is going to help with cognitive care, especially with our patients experiencing brain fog, the memory loss, and even the high toxin burden as well. And it looks like Dr. Sarah is back, and we have a few questions here.
Fantastic. Thank you for covering. My dog has lost her mind, but she's doing better.
She's saying hi.
Yes, she is. She has a lot to
wants
say.
your attention.
Yes. All right, we have some good questions. Did you want to read the first one, or do you want me to?
Yeah, I can go over the first one. So the first one, this one's the CRP one. Okay. So it looks like, are we looking at CRP or HSCRP? So HSCRP is high sensitivity CRP. These are both inflammatory markers, right? It's the same inflammatory marker, but the HSCRP is just a more sensitive marker to inflammation. And this is both acute and chronic inflammation that is showing and possibly circulating within the blood. I will typically do HSCRP versus CRP. How about yourself?
Yes, especially because, I mean, having that increased sensitivity, you're getting a more accurate picture of what that C-reactive protein level looks like in the patient. So I agree.
Absolutely.
Yeah. All right, second question. Can you have a high B12 level and an MTHFR mutation? Usually, I actually see the opposite. So when you have an MTHFR mutation, it impacts the enzymes that turns homocysteine into methionine and methionine into those B12 and B9 vitamins. So when you have that mutation, you have less of that enzyme and you're going to have less of that conversion. But Dr. Cho, what do you kind of normally see with your lab levels?
Yeah, most of the time it is the lower B12 levels with the MTHFR mutations. Now, this is not with every patient. So, this is when you have to investigate what is happening. Why are they, if they have a MTHFR mutation and they're having high levels of B12, what's happening, right? So, you have to really dive into their nutrients, what they're eating, what they're metabolizing, their gut health, what kind of vitamins they're actually intaking. Or there is a rare condition that occurs with a certain specific MTHFR where there's overmethylation that occurs, and you might want to investigate that as well. But that is a deeper dive within a different discussion, but that can
Yeah.
happen.
Yeah. All right, last question. How about glutathione in cancer patients? That is a very good question. I've been kind of combing through my textbook of naturopathic oncology book. And from what I've been able to see, supplementing with glutathione isn't necessarily contraindicated in cancer patients. It depends on where they are in their treatment. I am usually very conservative when it comes to working with cancer patients. So we're either working on prevention or survivorship or supporting or reducing the side effects associated with cancer treatment. So I think one would depend on the type of cancer, the staging, and where they are with treatment. But I would have to do a deeper dive on the research. But from what I've seen with the resources accessible to me, I haven't seen any major contraindications. What about you, Dr. Cho?
Yeah, there's the research right now is showing that there is research out there that's showing glutathione it can be really beneficial for cancer patients, especially cancer patients that are going through treatment, and it's been making their treatments more effective. But then there's other research that's showing that glutathione is a potentiator of cancer cells as well. And so this is where you really have to personalize it. And as Dr. Sarah was saying, you have to look at what staging are they in, what treatment approaches what treatment approaches are they utilizing, right? What type of cancer is that? These are all considerations. And if you want a conservative approach and you don't want to use glutathione because you're seeing that research, there's so many other antioxidants out there that you can utilize for your patients to help with that oxidative stress.
Yes, let's not forget vitamin C, vitamin E, all of our classic favorite antioxidants. Yeah.
Right. Absolutely.
All
Great
right.
questions.
Very good questions. Any other ones? There is a few more moments left to submit your questions. Um, in the meantime, I wasn't sure. I might have missed this. Did we chat about dosing for glutathione? Does your dosing options depend on the condition, the patient? How do you decide on dosing?
Yeah, it depends on the severity of the condition, right? So I will typically start low and go high with my patients, typically most of the time, unless they're having a very severe reaction, or having a very severe condition that I really want to bring down the oxidative stress levels. So that's anywhere between, I think it's 1,000 milligrams to 5,000 milligrams, with the liposomal, and or if mLs, it's 1 ml to 5 mLs with some of the liposomal glutathiones as well. You'll just have to look at what brand you're using and how it's being dispensed.
Exactly. Yeah, the form as well. Yeah, I do similar dosing, and then I will either do the liposomal version or an IV push at the end of a nutrient IV, or even like we talked about earlier, NAC, and kind of starting at the precursor and helping the liver make more. So lots of different options.
Right. I love a glutathione push.
Yes, exactly. Yep.
They're
Great way to
awesome.
finish off a good nutrient IV.
Yes.
Exactly. Yeah. Oh, good. A good question. Snuck in just in the nick of time. All right. How about omega 3s? Where would you start? I'm guessing this might be about dosing and maybe product selection. Honestly, my go-to omega is Pro Omega 2000. I've been using this omega since medical school, but Pro Omega 2000 by Nordic Naturals, 2000 or yeah, 2000 milligrams, 2 grams. Um, and that's usually my go-to. Sometimes you could do an algae-based. Nordic Naturals has one as well. And then if you have patients that are kind of picky about ingredients, particularly about the gelatin capsule, you can also do a liquid omega as well. What about you, Dr. Chill?
Yeah, mine go-to is Thorn Super EPA because about one capsule is about 1,000 milligrams, and it's fairly cost effective for patients, and it's been highly vetted. And I will typically start with 1 to 2 capsules and move up to 4 capsules a day. So you want the sweet spot is in between the 1 to 4 grams per day.
Yeah, very good. This brings me to a question. How do you feel about omega products that have SPMs or the inflammation mediating ingredients in them? Do you feel like it's a worthy addition to an omega formula?
I have still not decided yet.
Same, same.
I need to do a little bit more research and more personal clinical trials with the existing patients to have a conclusive statement on that.
Yeah, same. Same. Yeah. All right, one last question. How much, I guess, glutathione in an IV push? We usually do about, actually, I think the highest we'll do is 1,000. We'll do anywhere from 5 to 1,000. Really just depending on the sensitivity of the patient as well. In terms of milligrams, 500 milligrams or 1,000. Because if you do too much, it can be a little bit painful for them. So you definitely want to do a slow push. But what
Mhm.
about you, Dr.
Yep.
Chill?
Yep. That was very similar. So I haven't done one of those in a while.
Yeah.
But I think when we were doing it, it was anywhere between 1 to 3 milliliters, right?
Yep. Mm-hmm. Yep.
And it was a slow push.
Yep. Exactly. Well, wonderful. Thank you all so much for joining us again for another episode of the Functional Solutions Podcast, brought to you by the American Academy of Functional Health. Um, Please do not forget to log into your dashboard. We covered quite a few topics tonight, so it might be good to go revisit a couple of modules. And of course, feel free to share and comment, and we'll see you all next Wednesday on the next episode. Have a good night.